Hi everyone. To start our knee video, we're gonna do the anterior section first. So you're gonna start with your patient sitting at the edge of a table, and you're gonna cup both of their knees and have them go into flexion and extension just to see if there's any abnormalities between the two, such as clicking, catching, or popping, anything like that. You can also check the temperatures of both of the extremities. Then you'll have your patient scooch back so that their knees are in extension. First, we're going to palpate the patella. We're going to look for the borders of the patella. We'll start on the lateral side and use your opposite hand to stabilize. Then the medial, the inferior pole, and the superior. At that inferior pole of the patella, this is where the patellar ligament starts or originates. And if you palpate distally to the tibial tuberosity, that is where the ligament will insert. At the superior end of the patella, this is where the quadriceps tendon is, and this connects to all of the quadriceps muscles, starting with the vastus lateralis, the vastus intermedius, and the vastus medialis. Above all of these muscles is where the rectus femoris lays, and if you have your patient really extend and flex their thigh, you'll be able to see these muscles more clearly. Along with these muscles, we also have the sartorius, which originates on the ASIS on the hip, and it's almost like a S shape, and will insert all the way down on the pes anseri. To inspect the medial aspect of our patient's knee, we'll have them go into knee flexion. From there, we're gonna find that inferior pole of the patella again, and then we're gonna slide our fingers inferior and medially to find this little divot, and that'll be where the medial meniscus is. If we follow this joint line and palpate distally, we will feel the tibial plateau. And if we palpate superiorly, we will feel the medial femoral condyle. Back to that joint line, we will slide superior, and we'll feel a bony prominence. This will be the medial femoral epicondyle, and this is where the MCL will originate. And if we continue to palpate distally to the tibial flare, that'll be where the MCL will insert. Next, we will palpate the pes anseri tendon. So we'll go back to that tibial flare and we will slide distally. And this is where the semitendinosus, the sartorius, and the gracilis muscles meet to insert. Then we will go and palpate the semimembranosus tendon. So it's going to start posteriorly, and we'll feel a little tendon back here, and we'll follow it onto the tibia where it inserts. Next, we'll inspect the lateral aspect of the knee. So we're going to go back to that the inferior pole of the patella. And if we palpate inferiorly and laterally, we will find another divot. This will be the lateral joint space. And we follow that joint line and palpate distally, we will feel the lateral tibial plateau. This is also where the lateral meniscus is. And if we palpate superiorly, we will feel the lateral femoral condyle. Then we will palpate the fibular head. So if you travel down from that joint line Right here you'll find a bony prominence, and that'll be your fibular head. This is also where the LCL will insert. And then if we go back to that joint line and palpate up, this will be the origin of the LCL. Back to that fibular head, if we palpate distally and go side to side like that, it might feel a little weird because this is the fibular neck. It's also where the fibular nerve is. On the lateral side of the thigh is the IT band, and it originates in the hip and inserts on Gerdy's tubercle on the tibia. On the posterior aspect of the knee, we will find the popliteal fossa, which will be right above the joint line. And then we will find the posterior muscles that act on the knee as flexors. This will be the biceps femoris, the semimembranosus, and semitendinosus. Then we'll palpate the gastrocnemius heads, both the medial head and the lateral. And then we'll find the popliteal artery.
One of the best ways to get to the conclusion about a patient's injury is by looking at their past medical history. Their past medical history can tell you a lot about them, such as if they're more susceptible to certain injuries or if past injuries have had an effect on what they're experiencing now. By asking the right questions to the patient, you can understand why they might be experiencing the pain and what exactly is going on with them. Some questions that you can ask about their history is, have they ever had an injury like this before? Because if they have, then you can ask them what they did for it and how it occurred before, because there could be certain similar circumstances to why it's in pain now, and also what the pain feels like. I think that's a very important question because it could be tingling, it could be burning, it could be sharp pain, we don't know. And by asking that, we can eliminate certain pathologies already off the bat. Is there night pain? That could be a more serious injury, and it's important to ask. If they're having trouble weight bearing, that can be important because there could be certain things associated with that, such as if they're wearing the wrong shoes, which could be an easy fix, but they might need to take time off sports if they're an athlete, or just relax and non-weight bear for a while, which might be very hard for some people. Also, if they remember how it happened, it sounds simple, but a lot of people sometimes, if it's a chronic thing, don't remember how it happened. They might be able to tell you when it started, but they might not be able to exactly tell you this happened on this day. And is there history of arthritis, like rheumatoid arthritis or osteoarthritis? Because this can also help determine what pathologies it might not be and get closer to the actual conclusion. And also, how long has the pain been there? Was there a noise?
Okay, so we're going to be demonstrating the special test when looking at knee injuries. And so this test is called the posterior drawer test, and you're looking for sprains or ligament tears in the knee, specifically the PCL. And so what you're going to do is you're going to have the person lying supine on their back with their leg bent at an angle of 90 degrees to 45. And you're going to come to the front and you're going to grip just right where the fibula and the femur and like the patella joint is. And you're just going to kind of grip like this, and then you're going to shift downwards, and you're looking for joint laxity, which will indicate a PCL sprain and or PCL tear. So this test is the Godfrey special test, and this is looking also at a PCL sprain. So you're gonna have the person bend their legs to a 90-degree angle, hold it here, hold it there, and you're looking for bilateral symmetry. And if there's only, say, one leg has like a partial dip right here at the joint for the the fibula, the femur, and the tibia, that would indicate a muscle, like vascular indication of a PCL sprain and or tear. So you would look just for that straight line, and if you see a dip, then that would indicate that like laxity. All right, so this special test is called the prone Walkman's test. And so you're gonna have the person lying prone on their belly, and they're gonna have their both legs hanging off the edge of the table, like have their kneecaps kind of showing off the edge of the table. And you're going to pick up the back of the leg of the potential injury, and you're going to hold them about a 20 to 25 degree angle, and then you're going to put your hand right on the back of the gastroc, and you're going to push down, looking for a shift in the tibia and the fibula, just kind of like a gliding off the femur. And if you find that laxity occurs, then that is an indication of a sprain to the ACL. And you can do it on both sides, looking for bilateral laxity. It's possible that that's just what the person has, that kind of mobility, but this would be a positive indication of an ACL sprain. So this is the special test. It's called a valgus stress test, and this is looking at a sprain, tear, and or injury to the MCL joint. So you're gonna have the person lying supine on their back with both legs extended, and then you're going to pick up the injured leg, and you're going to put pressure right here on the IT band area, and you're going to push inward, and you should look for any joint laxity in terms of your MCL, which is on the internal part of the leg. And so when you press, if you see any bowing or just any movement that like is abnormal for that person, you can do a bilateral test to see if it's similar on both sides, or if there is some indication of laxity on this leg. Okay, so this is a special test or muscular test for the quadriceps, and you're looking to see if there is a sprain, grade 2 or grade 3 on the PCL. And so what you're gonna have the person do is lie supine on their back, and they're gonna have their leg bent at an angle, and then you're going to put pressure on the ankle to like shin region, and then you're going to have your hand here on the quadriceps, and you're going to have the person actively try to lift and like engage their quadriceps, and you're gonna look for displacement of the tibia and the fibula, looking to see an activation of that ACL. And so, Natalie, can you engage your quadriceps, please? Keep your foot on the table. And so by doing this, by creating that resistance, you're looking for a glide of the tibia and the fibula, and that would indicate laxity of the ACL, and that would then indicate a sprain of a grade of 2 or 3. So this is a special test looking for the proximal talofibular syndesmosis. And so what you're gonna do is you're gonna have the person have their leg planted and at a 90 to 45 degree angle, and you're going to keep one hand on the tibia, and then you're going to have one hand on the fibular head, and then you're going to try to displace the fibular head by going either anterior or posterior. And when you're doing that, you're going to look for any possible shifting or any laxity within that area, and the patient may present with pain upon the special test. And so pain would indicate a injury and or damage to the peroneal nerve that travels down this side. But when you're looking for shifting, if there's an anterior shift, there's going to be damage and or strain to the patellar talofibular ligament, or a posterior displacement would indicate a syndesmosis.
Okay, the first test I'll be demonstrating is called the Slocum drawer test, and this test for rotational knee instability. You're going to have the patient lie in supine position and flex the knee at a 90 degree angle. You're going to want to internally rotate the tibia at about 25 degrees, sit on the patient's foot, and align the thumbs along the anterior joint line and draw the tibia anteriorly. You're going to want to repeat this process, but instead externally rotate the tibia about 15 degrees and repeat the process. And a positive test is indicated by an increased amount of tibial laxity compared bilaterally. Next test is called the crossover test, and this also tests for rotational knee instability. The patient is in a standing position, and you're going to have the patient cross the uninvolved leg over in front and rotate their torso in the direction of the movement. And then you're going to want to take the same uninvolved leg and cross it in the back, moving the torso again. And if the patient reports any pain or instability, this is a positive test, and this indicates instability of the lateral or medial capsular restraints. This next test is called a pivot shift test, and this tests for an ACL rupture. You're going to have the patient lie in a supine position and take the heel or the ankle and internally rotate the leg. And then you're going to apply a valgus force and take the knee from fully extended into a flexed position. And a positive test would be indicated by a clunk or pain in the patient. This next test is called the Slocum ALR test, and this tests for anterolateral rotational instability. The patient is going to be lying on their unaffected side. Their unaffected leg is flexed at the hip and knee for stability, with the affected leg only slightly flexed. You're going to place one hand above and one hand below the knee and place a valgus force while moving the knee into flexion. A positive test would be indicated by a clunk or pain or instability in the patient. This next test is called the flexion rotation drawer test, which also tests for anterolateral rotational instability. You're going to have the patient lying supine, and you're going to raise the calf and ankle, flexing the knee about 25 degrees. One hand is behind the knee to stabilize the position, and place your other hand anteriorly and depress the tibia posteriorly to the femur. And a positive test is indicated by increased laxity, which could indicate a tear in the ACL, LCL, or biceps femoris tendon. This next test is called the dial test, and this tests for posterolateral knee instability. This test could be done in supine or prone position. I'm demonstrating it in prone position. So what you're going to do is you're first going to bring the patient's knee into flexion at about 30 degrees, and you're going to externally rotate the patient's lower leg. And we're looking for asymmetry, and if there's an increase in external rotation more than 10 degrees compared with the opposite side. That could indicate an injury to the posterolateral corner of the knee. You could then repeat this test with the knees flexed at 90 degrees, and an increase in laxity could indicate injury to the PCL. This next test is called the external rotation recurvatum. This also tests for posterolateral knee instability. The patient is lying supine, and you want to grasp the patient's big toes or medial foot and lift the legs to examine and compare knee extension and tibial external rotation. This test is positive if the patient has a hyperextended knee or if there is a difference in external femoral rotation or varus alignment.
So the first test that I'll be doing is called the posterolateral drawer test. This test is testing for posterolateral laxity in the knee. So you want the patient supine with the knee bent at 90 degrees. And then you're going to want to put your thumbs over the tibial tuberosity, and then your hands wrapped around the back. And then you're going to want to push down. And if there's extra laxity when you push down, that's a positive for posterolateral drawer test. And then you want to perform that test bilaterally too. The next test is called the reverse pivot shift test. This test is also testing for posterior rotary instability. For this test, you're going to want to have the patient supine and then have the knee bent, and then place the foot on your iliac crest for stability. You want your left hand on the back of the tibia, and then your right hand around the ankle. And then you're going to want to apply a valgus force by pushing with your left hand to the side. And then you're going to want to go back and forth, flexing and extending the knee, while still applying that valgus force. And then a positive for this test is increased laxity in the knee. So he's not positive. For this next test, it's also testing for posterior rotary instability. You're going to want to have the patient supine and then have the hip flex to 90 degrees, and then also the knee flex to 90 degrees. And then you're going to want to stabilize the knee with one hand, and then passively extend the knee as much as they can. Typically, you're supposed to extend the knee all the way, but some patients want to have the hamstring flexibility to do that, so just do it as much as possible. And if there's a clunk or a jerk in the knee, that's a positive for posterior rotator instability. This next test is called the McMurray's test, and this one's testing for meniscal dysfunction. And to do this test, you're going to want to flex the knee and the hip, and then have your fingers stabilizing the medial aspect of the knee. And then you're going to want to externally rotate the knee, and then this is testing for medial meniscus dysfunction. And then you're going to want to bring the knee into external rotation, and then passive flexion and extension, just pulling it through a bunch of different motions. And then to test for lateral meniscus dysfunction, you're going to want to switch hands, actually. And then palpate the lateral side of the knee, internally rotate the leg, and then also do that same flexion and extension going through the range of motion of the knee. And then positive for this test is just discomfort in that meniscus or like grinding or clunking. This test is called the Apley's test, and this is testing for meniscal dysfunction. You're going to want to have the patient lying prone, and then you're going to bend the affected knee to 90 degrees, and then apply stabilization with your left leg over the back of the patient's thigh, and then with both hands grasp around the upper ankle, and then squeeze, and then pull up, and then bring that knee into rotation, internal and external rotation, testing for pain in the knee. And then the pain would be a positive for this test. And then you want to do both lifting up and then also compression. So for the second part, apply compression by putting your elbow on top of the foot and then bringing that knee into internal and external rotation. The next test is called the Thessaly's test, and this one is also testing for meniscal dysfunction. For this one, you want to have the patient standing on one foot, and then have their knee bent around 20 degrees, and then they can grab your arms for stabilization. And then you're going to instruct them to rotate on their knee left and right 3 times. So go ahead and do that. And as they're doing that, you want to ask them if they're feeling pain in the knee or any instability. And then pain in this test would be a positive. This next test, called the Wilson's test, is testing for osteochondritis in the knee. And to perform this test, have the patient seated, and then instruct them to internally rotate their knee as much as they can, and then have them extend their knee all the way to 0 degrees, and then instruct them to internally rotate their knee all the way, so like that. And then if that motion relieves pain in the knee, then that's a positive for Wilson's test and osteochondritis. This next test is called the elbow compression test. And to perform this test, have the patient lying supine with the knee bent at 90 degrees. And then you're going to want to put your one finger over the lateral epicondyle, and then passively extend the knee all the way to 0. And this is testing for IT band syndrome. So I'll do it again. The IT band is right here, and what I'm doing is I'm holding or compressing the lateral epicondyle, and as I'm extending, the IT band would pass over the lateral epicondyle, causing pain because it's inflamed, and then it'll hurt as it goes over the splitting process. So.
To conduct a Q angle measurement test, have the patient either lie supine with the knee fully extended, the ankle in neutral, and the toes pointing up, replicating the standing position. Standardized foot position improves the reliability of this assessment, or you could have the patient stand with their feet shoulder width apart. The position of the examiner is standing on the side of the limb to be measured. The examiner will then identify and mark the ASIS, the midpoint of the patella, and the tibial tuberosity. A goniometer is placed so that the axis is located over the patellar midpoint. The center of the stationary arm is over the line from the ASIS to the patella, and the moving arm is placed over the line from the patella to the tibial tuberosity. A positive test is a Q angle greater than 13 degrees in men or 18 degrees in women. The implications for this test is increased lateral forces, which lead to a laterally tracking patella. For the medial and lateral patellar glide, the patient's position will be supine with a bolster placed under the knee so that it's flexed to 30 degrees. The position of the examiner will be standing lateral to the patient. The examiner will then, for the medial glide test, move the patella medially, placing stress on the lateral retinaculum and other soft tissue restraints. For the lateral glide, the examiner will move the patella laterally, placing stress on the medial retinaculum, VMO, and medial capsule. A positive test for the medial glide is if the patella glides 1 to 2 quadrants, approximately half its width medially. Movement of less than 1 quadrant is considered hypomobile. Movement in more than 2 quadrants is hypermobile medial glide. A positive test for the lateral glide is normal lateral motion is 0.5 to 2.0 quadrants of glide. Less than that is hypomobile lateral glide. Greater than 2 quadrants is hypermobile lateral glide. Implications for a medial glide is if there's tightness of the lateral retinaculum or IT band. Also, if there's laxity of the lateral restraints. Implications for the lateral glide is if there's tightness of the medial restraints, specifically the medial patellofemoral ligament, or if there is laxity of the medial restraints. It's important to note that the patient may be apprehensive during lateral glide tests and can be fearful that the motion could result in a patellar dislocation or sublation. Another note is that hypermobile lateral glide can create predisposition to patellar dislocations. For the apprehension test, the patient will lie supine with the knees extended. The examiner will stand to the patient's side. In this case, the examiner will be testing on the left knee. The examiner glides the patella laterally as far as possible without dislocating it. A positive test is indicated by the patient's contracting the muscles or showing apprehension of an impending subluxation or dislocation. Laxity of the medial patellar retinaculum predisposes the patient to a patellar subluxation or dislocation. To test for a medial synovial plica, the patient is seated or lying supine with the knees flexed. The examiner will stand on the side being tested. With the patient's knee flexed to 90 degrees and the tibia internally rotated, the examiner passively moves the patella medially while palpating the anterior medial capsule. A positive test is when the patient describes reproductions of the symptoms. In addition, the clinician may feel the plica as it crosses the medial femoral condyle, especially in the range of 60 degrees to 45 degrees of flexion. For the stutter test, the patient would sit with the knee flexed over the edge of the table. The examiner would stand lateral to the involved side, lightly cupping one hand over the patella, being careful not to compress the articular surfaces. The patient would then slowly extend the knee. A positive test is when irregular motion or stuttering between 40 degrees and 60 degrees as the plica passes over the medial condyle.